Akhmadieva, and I'm from Russia. And all of you know Boris, of course. For those who haven't met me before, I'm a medical doctor, and most of the time I work with my patients and I teach my students. So I do not know that much about all sophisticated things that most of you know about and talk about and teach about. But I'm here to present the results of the work that Boris and I did, and I think that it will be quite practical, and I think that it might help some of our patients with whom I'm dealing for most of my professional life. Next. First of all, I would like to say thank you to everybody who made it possible for me to come here, beginning with Tuck Users Group and everybody who supported the bursary and the idea and everything that I appreciate that much. So just to show that I mostly work with the patients, I would like to show you the website and to show what I usually do, examining patients, and this is actually the front page of our Department of Neurology of the University Hospital, and this is one of the stroke patients. So this makes it visible that stroke patients are an important problem, and that we know and we try to know. We know how to help most of them. We would like to know how to help more. And this small research that Boris and I started, I guess, will add another grain to this big box. Next, please. If nobody minds, I would like to show you a small video about stroke just to make sure that everybody knows what we are talking about, although Boris told me that nobody is interested in stroke.
My grandmother had a severe neurologic disease, and she had difficulty speaking. She lived with us when I was 2, so I think that really got me into neurologic communication disorders.
Better.
I wanted to study aphasia and become a stroke neurologist. So when a stroke happens in the brain, there is a clot to a vessel, and the blood flow doesn't get to that part of the brain, and that part of the brain dies. And the location is incredibly important in terms of what the deficits are initially after stroke, and then also how well a person can recover, because the brain is not homogeneous with respect to what functions are going to be impaired after you have a stroke. Now, language is an incredibly complex network. Say you want to name a picture of a chair. You actually activate most of your left hemisphere, because naming a picture of a chair involves the frontal lobes, the parietal lobe, the occipital lobes, the temporal lobes. Also, it's a huge network of areas just for a very simple language task. So I'm doing some studies of transcranial direct current stimulation and recovery, and that is a very benign electrical stimulation, low current stimulation that's non-painful, doesn't have any side effects on the person, but we think that it actually facilitates synaptic plasticity and reorganization, and the idea is to try to get the undamaged parts of the brain to take over for the damaged parts of the brain, to see if it can facilitate language recovery in a number of neurologic conditions. So there's new pathways that are set down, and so people can continue to recover for the rest of their lives. In fact, at least 25% of people recover completely independent lives after stroke, even after a large stroke, and that's because the brain is just an amazing organ.
So all doctors all over the world think the same thing, that patients need help, that recovery will take many months, years, weeks, so at least much time, and that we can help and facilitate recovery. Next, please. So some just words about stroke and its incidence. This came from the very last report about heart disease and stroke statistics from American Heart Association and Stroke Association, and it is updated very recently. it says that here you can see different risk factors for stroke, and green bars are good, red bars are bad, and it says that almost everybody who is older than 20 years old, and I think all of us are, have quite a lot of risk factors, so nobody is guaranteed that he or she will never have any event in the brain. That's why I guess this makes it even more important. And the prevalence of stroke is really different in different age groups, and the older the person is, the more is the prevalence. Next one.
I think it's the last one.
No.
Oh, no. Yeah.
And stroke is a really expensive disease. And this report says that it will be even more expensive in 2015, 2020, and even 2030. So all of us would like to do something for these patients to make their life easier. And if it is not very expensive things, it is very nice, because all medication and all pharmaceutical inventions are extremely expensive in their, should I say development?
Yeah.
Okay, next one. We made a couple of studies, and this is one of them, about quality of life of patients with different disorders. And stroke patients are those who suffer quite a lot, and all the domains of their quality of life is really reduced, and this is another thing why we should help them. Even at the websites for non-professionals, it is written that stroke can manifest in different types of disabilities, including physical disability, including cognition problems, and this involves perception, memory, the ability to read, the ability to understand, and that's why I guess I'm here presenting these results, and that's why we decided to make this small, I would say, just pilot study, and I hope that it might be continued if we, Boris, myself, my students will decide to do that. So memory, attention, and perception are three main domains that are involved in cognition problems in most of the patients with stroke. And the most recent papers say that almost every patient with stroke has some cognitive impairment, and this impacts the emotional life, the social life, the psychological status, and that this is something that we should make the life easy with. Yep. So our study was devoted to a very simple thing. We decided to see if the layout of the text that is given to a patient make a difference for a patient, because almost all patients who suffered, who are stroke survivors, have to be rehabilitated, and most of them, actually many research show that the written instructions is a very good addition to oral instructions, and that if something is told to you and you get a paper where it's written the same thing, it makes a difference. But the patient will remember it better, will take the notes with him, will follow the instructions that are written down. Although many patients have, and the video showed this, have different damages in different parts of the brains, and some of them cannot really read. Some of them cannot understand at all. Some of them cannot see at all. But there are patients, and most of the patients, who can read and who will need the written instructions or the written advice and recommendations how to behave after stroke and what to do. Next, please. So we decided to do the continuation of the work that we already presented a couple of years ago. Those who attended that meeting might remember that at that time we examined healthy volunteers, healthy students, and we tried to see is there a difference, any difference when they read serif typed texts and sans serif typed texts. And that study showed us that there was no big difference for normal, healthy students. Now we decided to see is is there a difference for patients with some brain damage? Next, please.
You want to show texts?
Yeah, it would be very nice.
Okay. Just a moment.
So, Boris was very kind to make the layout of the text.
Texts are in Russian.
Yeah,
Okay.
the texts are in Russian,
So
but I think that nobody really minds the language
yeah,
here.
this is sans serif, and here is serif. As you see, it's very close. If you see here, yeah, thank you. As you see here, sans serif and serif is very close. It's the same paratype superfamily, and the biggest difference is basically one is serif and this one is sans serif. So we just took the text and made
Yeah,
it.
so I created the text, and we made these texts really useful for patients. So we have
Okay.
we have 4 types of texts, and all of them were devoted to rehabilitation after stroke and gave the advices for patients about their future lifestyle, about their eating habits, about what medications could be useful and which ones should be avoided, about the diseases that can underlie the stroke and that should be treated as the cause of the stroke, etc. So this information was really important for patients, and we thought that this is ethical to give a patient something that will be relevant for them, not just something that is from our crazy fantasy.
Yeah.
So I asked one of my students to perform all of this, to print out and to give this text to patients and to measure their speed of reading. And after each text, so a text was on 1 page, each text was less than 1 page and close to 1 page. And after each of them, we gave them 10 questions. And each question has a multiple choice answer. So a patient should read the text, and we measured how long it will take a patient to read this text. Then we gave them this set of questions with multiple choice answers, and then we measured the number of correct answers. And all these questions, of course, were related to the text that they just read. We made it as a randomized control study, and we made randomization with computer software. So we divided patients into 2 groups, and one group read serif text, then sans serif, then serif, and then sans serif. I just mentioned that there were 4 texts. And another group started with sans serif, then serif, etc. So actually, all of them got all 4 texts. And we measured the time and the number of correct answers. Next, please. The selection criteria that we used here were quite simple. So we invited the patients who had stroke, and which was documented by computer tomography and by clinical examination. All of them should be able to read, so we did not invite patients with total aphasia, with blindness, with dementia. So all of the patients were those who can read, who can understand Russian language, who were not demented, who were not aphasic, and who signed the informed consent to participate in this study. So it was their voluntary decision. And for this study, we really cannot take many patients because this is just the beginning, and the number of patients in this study so far is just 19. But as I told you, this is the pilot study, and we will see how it will work, and probably in the future, if we will think that it is worth it, we can make kind of subgroup analysis for patients with different types of strokes, for patients with different duration of time after strokes, for patients with different zones of the brain that are affected with stroke, etc. So this small group included 12 males and 7 females, and the average age was about 55, which is actually quite normal for average age of patients after stroke with not that severe stroke. Next.
Okay.
Here, we're just to remind you of our previous study with the healthy volunteers, with students. We put together this data, and it occurred that all our students read faster than all our patients, and you can see the difference. And actually this confirms that even though we invited patients just with minor strokes, those who can read, who are not demented, and we performed special tests and clinical interview for exclusion of dementia and significant cognitive decline. So actually, all of them, I think, have some cognitive problems with memory, problems with speed of reading, problems with perception. And I guess that here you can see another thing that surprised Boris most of all, that this was not the aim of our study, but we decided that it's a good idea to compare the number of correct answers both from the students from our previous study and from the patients from this study. And we were quite surprised that the difference was not significant though, but still there was a tendency that our patients made it better than my students previously. Boris says that this is probably because the patients were more motivated for reading this particular text, and the text for students was from some classical literature, and this made no real sense for them. So I don't know, this is just a side note. And as Michael told us, I just told you what we're going to tell about. Now Boris will tell you what we are talking about, and then we will come back to what we've just told about, and I think we will manage that.
Okay. Here are the results of comparison of SANS and serifs. Here is the reading speed, words per minute. As you see, I don't put statistical stuff with the test significance and so on, but just looking at this, you see that there is absolutely no difference. Again, we have had just 19 patients. It was much more difficult to find volunteer patients than volunteer students, but still. Here is number of correct answers. Again, it's not statistically different. What we decided to do, think we could not do with the students, because with the students we just divide them into two groups. One read SANS, one read serif. Here, since we had 4 texts, and each participant read 2, we could take each participant. Yeah, 4 texts, yes. Each participant read 2 texts in serif, each participant read 2 texts in SANS. So what we could do, we could just compare the speed for the same patient. So what I'm going to do, I'm going to plot on this, on x-axis, the words per minute for serif, for y-axis words per minute for SANS. And if you are in the upper triangle, it means that you read faster in SANS. And if you in the lower triangle, it means that you read faster in serif. And if you are exactly on the diagonal, it means that the speed is the same. And
so each dog is a patient.
Yes, yeah, and this is in statistics people call this paired tests. You have Fisher tests, which basically says compares average speed. You have Wilcoxian tests, which compare just how many people read faster one than another. And again, I don't want to give you the numbers because just the graphs are enough to say that there is no difference in speed. And here is another.
I love numbers, Boris does not.
I work with numbers. I have so many of them, so I love pictures. Okay, here is the number of correct answers. And again, if you look at this, you don't see any difference. Some people have more correct answers with SANS, some people have more correct answers with serif, but you don't see any tendency here. And again, the power of this study is very low because we had very small number of patients. We would like to have more of them, but
this is just the very beginning.
But it's a very beginning. It's very beginning. Well, and again, it's very easy with students. You just say, okay, we have a test, and you just come to the next room. You can do. It's absolutely unethical to do it with with anybody else, basically. So
actually,
that's
our students also were informed and consented
Yeah,
to
yeah.
participate in this study.
okay.
I'm very sorry.
Okay,
I'm
okay,
very,
okay,
very
okay,
strict
okay,
about that.
okay. Let me tell this. Yes, students are informed, they consented, but you tell the students, okay, he is another student, and this is this is term paper for this student. If you don't participate in the research, it would be difficult for your friend to finish his term paper. So why don't you
Boris
help?
never saw my students when we did this. Boris saw just the numbers,
Okay.
which he doesn't like.
Okay.
So, okay, let's stop this discussion and continue. With
Okay,
the
let's
paper.
go to conclusions. Okay,
Yeah,
okay, okay. There are two things. First is that it's very difficult to work with patients. It's very difficult to find a large population, and it's more difficult than with a healthy patient. And second, our very preliminary result is the same as with healthy patient, and is a healthy students. Excuse me, is with the healthy participants. And the result is this: that when you choose a font, you do it according to aesthetical principles. People tell you that you need to choose font according to readability, according to this, and have a lot of phrases like serif is going to be here, sans serif is there. Human brain, even after stroke, is very adaptable, and it can actually get almost anything. So just think about aesthetics.
I should say that in medical practice and in medical science, we have the rules how we should do the layout and how we should type the text for patients. So we have some advice and recommendations about the size of the letters, so how they should be aligned, etc. So all of this is on web, so it's freely available. There are some rules how we should have the papers that in the boxes with the pills, how do you call it? Got some kind of instructions.
Leaflets, they're called leaflets.
Are they? Okay.
Yeah.
So how should these leaflets should be laid out and what kind of letters should be there? As a practitioner, I really do not see that it is followed all the times, but still, yeah, nothing was written there about serif and sans serif, and that's why we decided that this might make a difference and that it wouldn't hurt if we will perform this small study, and maybe we will continue it and we will enlarge the number of patients because because my student Lilia Nuretdinova, whom I mentioned here, she is still active, she is still medical student, she is still doing this research even now when I'm here enjoying myself in Oregon. She's doing her job in our hospital, in Republican Hospital, which I also mentioned here. And I would like to say thank you to my students, the hospital, the patients, and TAC user groups for this presentation and for making it possible. Thank you.
I have a question. Can you go back to the, I don't need the mic. Back on the slide which showed serif versus sans serif in there was one outlier.
Дальше.
I think you went too far.
Yes, результаты.
There we go.
Yeah.
That guy.
Yes.
I mean, I find that very strange. I don't remember ever seeing an outlier in a type study before like that, where a person reads serif. I mean, can you interpret that dot for me? What is that saying? He reads serif at 180 and sans at 100?
Yes, exactly. He reads serif much faster than sans. I can look in my data and we can ask Lilia what was the profession of the guy, because I don't know, maybe he.
I almost wonder if there could. I mean, maybe there was some external factor that.
Yeah, maybe. Interesting question.
That's why I'm talking that subgroup analysis will be very useful. Maybe for patients with, let's say, right brain, it will be like this, and with left brain damage, it will be like that. That's why these plots are very important, because here we can see each patient. So if we are talking about this particular guy, so he is outstanding, he is different from the most of the guys there. And that's why we keep the data about each patient. We have a database with the names, with the addresses, phone numbers, and these patients allowed us to contact them if we wish. So we have all this database, and the study is to be continued, and that's why each dot is valuable here.
I had a question because in the last couple of years, I've had some family members come down with children.
I guess everyone has
Yes.
a family member who has so that's why it is important.
But was in your pre-selection, I don't recall seeing anything about testing for visual acuity. Was that done?
Second
But
eye.
don't need to retext, but was there an
Ophthalmologist.
optometrist or an ophthalmologist?
It was my medical students examined them clinically,
Okay.
and visual study was included. She had the tables with the numbers and with the letters, and this was one of the prerequisites for this. So, and the neglects, the hemianopias and things like that were excluded, so we had just the patients who can read, and they say that they can read easily
Right.
for this particular study.
Like, I mean, this is perhaps way too much detail, but when my mother started to suffer a serious stroke, her cognition was compounded by the fact that she was having issues in the retina. So she was, with a huge magnifying glass. So was it cognition or was it symbol?
It could be actually anything because the eye is connected to brain, and it could be the damage on any, I would say, portion of this tract. So it is very individual for each patient. And when we do clinical trials, many people laugh at us saying that your selection criteria has nothing to do with real life. And sometimes this is true, but anyway, we should start with something. And when a physician makes a decision, will, for instance, this method be appropriate for this particular patient, we see which studies have been done before, and if my patient is close to the population for which these studies were done. So that's why it will never be possible for a computer or robot to make a decision, because each patient is individual, and we have to compare different groups and different patients. And sometimes studies say that this drug is very nice, and we can, let's say, see contraindications that this drug will be absolute disaster for this particular patient. So it's quite, Boris just told you that it is very difficult to work with patients, and he made this tragic face. But he was absolutely right in that case.
Going back to the plot, the optimistic thing it tells you is that for 5% of patients, we can make a difference with a zero-cost solution. Normally, that's about as good a suggestion as you can make. Now, there's not enough data to know whether that 5% is real, but it says if this is truly representative, then for 5% of the patients, we can make a difference, and it doesn't cost anything.
Thank you very much, Alan. And in medicine, we have paradigm that even if we can make a difference for one patient, it's worth to work on this problem.
Have you studied the male-female difference?
Not now. We had just 19 patients. I guess 12 of them were male and 7 females.
Yeah.
So we didn't study it at this particular point, but we definitely will.
As I recall, in our study with healthy students, we checked whether male or female. We didn't find gender difference.
Yeah, but we have hundreds of students.
Yeah, but then we have 300 of students, so we could do a lot of tests.
Okay, there's some other variables that I think might be worth exploring. One is the typeface use. Some typefaces are much more readable than another. Take a single individual, let them read the same text in multiple faces, and they'll have preferences. The second one is the width of the line. The longer the line, the harder it is for the eye to come back to read the next line. And the third thing is the baseline skip. And I raised this issue because a couple of years ago I was in the library and I pulled a detective novel off the shelf, and I thought I might like to read it. But after reading a couple of pages, I found out I couldn't. And the reason was it was set on such a tight baseline that it was just incredibly visually tiring to separate one line from another.
There was a paper, very influential paper by Bigelow, from Bigelow and Holmes, and I think Lang was his co-author, who studied X height. for healthy people. And what they found that there is, they call it, I think, comfort zone. So if you are below comfort zone, it's bad. If you're above the comfort zone, it's good. But if you're inside the zone, it doesn't matter. And I think it goes with X height and V. So you have some comfort zone and you just don't go from it. As to changing typefaces, I can agree that different typefaces might have different readability. But what we wanted to study here, just one typographic element. And for this, we wanted to take exactly similar typeface with just one, scientific, just make one small change. And small change it's very difficult to do because usually when you have serif and sans serif, there is a lot of changes. Counters are different, heights are different, so on. And we were very lucky with Paratype, who released for open source community their excellent fonts, and they had exactly serif and sans serif variants. We were absolutely happy to experiment with this.
And about the length of the line.
Yeah.
So we also did this with healthy students, and in that case we did not find any difference. We gave them the long lines and short lines, like one column and two columns, and even landscape and portrait, and we didn't find any difference in the speed of reading and in comprehension and in the number of good answers. But actually we will really appreciate everybody's advice on what else could be added into this study to make it, as Alan said, cheap and might be important.
So maybe two more questions, Carl.
I just had one small thing, which is, did anyone, either healthy student or patient, spontaneously say anything about, gee, this is serif and sans serif?
Not as far as I know. Actually, I was not the person who gave the text, but we were working together with my medical student, and she was very responsive. She told me everything. Medical students could get excited very nicely, so she told me about their family stories and things like that, but nothing about this so far.
Would it be interesting, it might vary from patient to patient, to compare reading on paper with reading on screen?
Yeah, this is very interesting because the contrast is different, lots of things is different, but I know about experiments with reading on screen, but you want to control everything. You want to control the lights, you want to control the resolution, so on, and basically people construct special devices for this, and this is not cheap. And
Actually, it's a very nice idea because many patients use their iPads, use different e-books for reading. Many patients, so it really depends. Many of them prefer papers, some of them prefer electronic things. And I'm not aware of any research done for this for patients. Maybe Boris knows about healthy people.
well, yeah, there is lots of papers about healthy people, about sizes and so on. I remember people did this. I don't remember anybody comparing screen and paper. They usually compared different fonts for screens. But the classical question, what would you prefer, e-book or paper book with the same text? No, I don't remember anybody asked. It's a very good question.
Is anybody aware of any kind of study for healthy people comparing screens and papers?
Ask Chuck.
Yeah, wonderful biologist who will know much more than everyone else in the auditorium. Jennifer, what are the results?
Well, I don't know about the relative scope, but like with the autism studies versus healthy studies or even normal cognition studies, there's some with on-screen iPad reading, and I believe that actually happened at UCSD, but I don't know that for sure.
Okay,
if you can find and send it, would be great.
And if you can send me the link, I will appreciate that.
Okay, sure.
Your metric was correct answers on a test.
Out of 10, yeah.
Out of 10, and I assume the test was immediately after, or very shortly after reading?
So they read the text and they were given the questions, yeah.
Right. The purpose of the instructions is for this patient to follow them later. So the question is another metric useful to be, 1 week or a month later, see how many questions they get right?
Again, Alan, we did this for healthy students. Yeah, you might remember that. We probably report this
Yeah.
as well.
Yeah.
Yeah. And this might be the next step of our study. And I think that this is even more important than what we recall at the moment.
That's right. When they're in
Since-
front of the doctor, they'll remember a lot.
I don't think so.
Yeah, yeah.